Namaste and good evening, everyone. A very warm welcome to Onco Forum 2025 Day 2. We are honored to have you join us for this two-day event. We look forward to insightful discussion and meaningful learning this evening. With immense pleasure, I would like to invite program convener Dr. Asim Sama. He is a senior consultant medical oncology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. It's over to you, sir.
Thank you. Thank you, madam. And thank you, Team Horizon, for this managing this Onco Forum meeting. So this is the day 2 for this Onco Forum meeting, and today we will be discussing about two very important cancer, that is genitourinary cancer, and we will discuss prostate cancer in great detail. For that, we are having the esteemed faculty and our favorite sir. So Dr. Lalit Mohan Sharma will be moderating a session where he will touch upon the various aspects of the CRPC, and there are many new things and new learning which we will be able to learn from him, and he will be, I guess, touching about the genetic part of this and the recent development in the treatment of the prostate cancer. So in this year, actually in the second half, there are recent few development in the prostate cancer, so we will be touching upon that. And I would request to Dr. Lalit Mohan Sharma sir. So he was with us in the Bhagwan Mahavir Cancer Center, and now currently he is senior consultant medical and pediatric oncologist in the Mahatma Gandhi Hospital. So sir is on the post of Professor, Department of Medical Oncology in Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. So sir, over to you. Please, sir, proceed for panel discussion and moderation, sir.
So much, Asim, for your kind words. And I think we are still working together. It's not that I have left
Yes, sir.
Mahavir and joined some other center. So we are going apart. We all are part of the same earth and we stay in connection with each other. So
That's true.
thank you so much for your energy, enthusiasm, and making us read, in fact, repeatedly. And I think
Yes, sir.
you
It's
are
a mutual process, sir.
now you are the mastermind, or you have arranged for master class on genitourinary and prostate cancer. So it's always a good pleasure, great pleasure to talk to you all guys, and we learn from the youngsters. So Sakshi, can you confirm that Dr. Sandeep Jasuja is available, so that I'm sure that who is available? Dr. Sandeep Jasuja, Dr. Beniwal, Dr. Dadich, Dr. Rohit Swami, and Sachin. And I can see Dr. Sachin and Dr. Hemant Dadich, I can see. Who else is available?
Sir, I am
Dr.
also here.
Sandeep
Good evening.
D'Souza will be joined.
So Rohit Swami is there, and
Yes, sir.
yes. And Dr. Jasuja and Dr. Beniwal are not yet available.
Yes, sir.
Both are not available, and Dr. Beniwal and Dr. Sandeep.
Yes, sir.
They will be joining, sir. Jasuya se baat hui thi, so
Ah.
he's about to join.
No issues, no issues. So meanwhile, I think Dr. Asim, we will keep you as an expert and we will keep some inputs from you if
Sure,
needed.
sir.
So without wasting much time, slides have already been shared to most of us. So this is an old case, 48-year-old gentleman, no comorbidities, lower urinary tract symptoms, high PSA, prostatomegaly, biopsy suggestive of high risk adenocarcinoma. So anything else, Dr. Sachin, you want to know from the biopsy or from the available investigation, or this all is good for you to start the treatment? Sachin, are you there?
Yeah, yes, sir. Can you hear me, sir?
Yeah, I'll request you to keep your cameras on so that I can keep seeing and lot of
Camera
energy.
and mic both are on. So can you hear me, sir?
Yes, please go ahead.
So as the PSA is correlating basically with the histopathology finding the adenocarcinoma of the prostate. So from biopsy point of view, it's okay. And to see the extent of the disease, we should plan for the plasma PET CT scan, sir.
Right. And I think in addition to that, we need to know the absolute value of PSA so that we
Exactly.
We can keep monitoring of the PSA.
Exactly.
Next slide, please. Other important thing to me, it appears that like 49 age is too young age for prostate cancer. So we need to think of certain molecular test also at this point. So this is TMH review, and we can see the PSMA PET CT scan, which is suggestive of extensive disease, which is high volume disease, and the histopath report is in front of us. So we can see this is like grade 5 WHO, grade 5 disease. Next slide, please. So this is the final based on PET CT scan, multiple bone mets, retroperitoneal nodes, and very high PSA, adenocarcinoma Gleason score 9. So now the diagnosis is clear. This is prostatic adenocarcinoma. So Dr. Hemant, how do we handle from here? How do we handle from here?
Yeah, basically, patient is very young and has a high volume disease. So definitely, disease is aggressive, and in young age, metastatic prostate, high volume. I will ask some genetic test for this patient.
Very right. So you're asking for genetics. So which type of genetic test you will ask for?
Yeah, I will ask a comprehensive genomic panel like HHR, HRD, MSI. These tests I will ask.
Right. And how about the treatment part? That is one side. How about the treatment part?
Yeah, definitely this is a high risk. So usual metastatic sensitive prostate cancer with the hormone sensitive patient, we will give uh, uh, young patient, no comorbidities. So docetaxel plus other like abitron or darolutamide we will add. Means either patient if a patient not has received any LHRA agonist or antagonist or castration, so we will give either LHRH agonist or antagonist or docetaxel plus any abitron or darolutamide.
Dr. Rohit, do you
Yes.
have anything over and above what Dr. Hemant has mentioned? He has very meticulously covered most of the things.
So, sir, treatment plan, I agree with the Hemant, sir, that I'll go with ADT plus docetaxel plus abiraterone or darolutamide. And even in the genetic part also, I'll like to go ahead with the BRCA1, BRCA2 and HRR pathway analysis as well as MSI analysis in this patient.
So in the ADT part, do you have any preference for agonist or antagonist or orchiectomy? How do you take that decision?
So basically, there is no preference, but such a high burden of disease and such a high Gleason score, I would like to go with antagonist only, so that there is no flaring up of the disease. And then again, I am going to use, if I am going to use darolutamide, then I am assured that there will be no flaring up of this disease, and I can go ahead directly without with agonist also. But in such cases, I generally will prefer to go with the antagonist so that from the very beginning there is antagonism of uh, hormonal stimulation of prostate cancer cells.
Great. Dr. Sachin, anything additional or we can go ahead next?
Yes, sir, we can go.
Yeah, next slide, please. So this I think we have discussed.
Good evening. I am also here.
Yeah, welcome, Sandeep. So grateful to you. Thank you so much.
Sir, I have one addition in this your slide that though the treatment well discussed in detail by Dr. Hemant, but somehow we should have to do one mutation analysis ARV7. If that is positive, then they will not respond very well to this hormonal treatment and this abiraterone, and they are poor responders. So we should also include now the ARV7 mutation analysis in this androgen register mutation analysis hormonal. And one point is also that if the patient is BRCA1 positive, then I will not go for this treatment. Then because they are very good responder to this BRCA mutation positive drugs, PARP inhibitors plus, and we can add abiraterone along with that PARP inhibitors.
So Sandeep, is this ARV7 covered in the comprehensive genomic panel or
Sometimes not, sometimes not, sometimes not. So we have to look for that also.
and how common is this mutation?
So this is mutation, no doubt it's less common, but we have to take count because this is young patient and a high mutation burden
Very
patient. That's why we have to think of this AR mutation positivity in this young patient to prescribe the one of the best of best drugs to them.
Agreed. And Dr. Sandeep, can you highlight about the somatic or germline or both we should order if finances are not a barrier?
So ideally, we have to do both in these patients. And yes, if germline, then definitely we have to go for the treatments.
Agreed. Any other input from any of you? Dr. Sandeep has very well covered the high level part. In fact,
Yeah, if patient has some money problem, then I will go for somatic mutations. If it is negative, then germline.
no, in
Otherwise,
fact, I think we should consider at this point that if we discussed the science part mainly, so we should go for both. Agreed.
yeah, definitely.
Next slide, please. So this patient has undergone treatment. So he has received docetaxel, leuprolide, abiraterone, and zoledronic acid, and we can see the PSA has come down, testosterone also has come down, and there is a significant decrease in the disease burden. So after giving 6 cycles of docetaxel, the treating doctor has kept this patient in follow-up, 3 monthly follow-up with PSA. So, Dr. Sachin, you agree with this or you feel that this is not the right approach?
Sir, at present, with the high disease burden, nowadays we are planning for the triplet therapy, as Dr. Hemant already tell about that. We should add the docetaxel with abiraterone and with leuprolide. So in this, there is only two molecules. So preferably, we should use three molecules. And if they had already used the two molecules, then we can keep them in the follow-up, or we can give maximum 10 cycles of the docetaxel.
So, the third agent, you would like to use Anja or Ajat?
Sir, preferably what currently we are using is the abiraterone.
Abiraterone you will give.
Prednisolone.
And like after completion of 6 cycles with good response, you will slow down or you will continue docetaxel for total 10 cycles as you said?
Sir, we can stop with the sixth cycle and we can continue with the abiraterone again.
Sandeep, you also agree with the same that we stop the chemotherapy after 6 cycles and continue with abiraterone?
I agree, sir, with the Sachin. But somehow patient if responding very well and tolerating very well, that's the now depend on the personalized treatment. If the patient tolerating very well and good responding to the docetaxel, I prefer to go for beyond the two or three more cycles, 2 to 4 cycles.
Right. And Dr. Rohit, any comment on the doses of abiraterone? You keep it 1000 or 500?
So, sir, basically, 250 milligram along with the food is almost equivalent to the 1000 empty stomach. So, I generally prefer to give 250 milligram along with the food in
This is
these patients.
250 or 500?
250, sir, 250 with food.
Everyone agrees to 250 because I have heard 500 is equivalent to 1000 with food.
250, I think.
250? Okay, good. Next slide, please. So I think these are good measures that on one side the patient rather than taking 4 pills, taking 1 pill daily, and it is and many times patient do take one only. You advise them 4, but they feel ki 4 is too much. So this is what has happened that after the 8 months period, there is progression of the disease. So this is post docetaxel, and at this point he has been started on abiraterone plus leuprolide. Dr. Sandeep, many patients are coming to us. Do you use the continuous androgen deprivation therapy, leuprolide, or you give intermittent ADT? You need to unmute, please.
Yes, sir. Sir, that are again depend upon the patient's tolerance. One thing, second thing, patient side effect. So how patient is losing his bone density, how patient having muscle fatigueness, how patient losing his muscle mass because of the intensive deprivations. So if patient is tolerating very well and there is no major side effect, then we can continue in this side kind of risk patient. But if patient has long-term side effect, chronic side effect like losing mass, fatigue, or losing bone density, then I am prefer to go for single agent drug.
Agreed. And Hemant, you also practice the intermittent ADT in select subset of patient?
If young patient is there, continuous I will use. If no comorbidity, no cardiovascular, no like flare or breast enlargement, sexual dysfunction, then continuous I will use. Otherwise, intermittent.
Next slide, please. So like this patient is now progression after the abiraterone. So Rohit, before we move to the next discussion, how do you select between abiraterone to the other agent?
So, yes, sir. So, this patient progressed within 6 months on abiraterone, I think.
Yes.
So, doesn't appears to be so much hormone sensitive and has progressed within 6 months. So, I like to go and still a young patient. I like to go with the option of cabazitaxel in this patient. And after that, I like to go for enzalutamide if he tolerates and has a good response with cabazitaxel. And after progression on cabazitaxel.
Dr. Sachin, any comment on sequencing these drugs, abiraterone versus enza?
So in routine, we are preferred is the first line we are using the abiraterone, and on the progression or on the second line we are using enzalutamide.
Yes, that is true that we can use second line enza, but abiraterone after enza is not recommended. Sandeep,
Yeah.
if we are discussing it rightly.
Yes, one trial has shown that if we use means sequencing of abitron versus enza, if you use enza, then abitron won't work too much. So in that trial, if comparison shows that if you use enzalutamide after abitron, it will be uh, uh, correct sequencing.
Right. So at this point, cabazitaxel has
Sir,
been suggested. So you all agree for
in this, yeah, no, sir, in this patient, they are poor responder to ARS-CRA.
yes.
Because it's within short period of time, he loses the response of the arbitraton. Then I think enzalutamide will not be correct option in this patient. So I am totally agree with Sachin. Now we should move on to the cabazitaxel or kind of platinum therapy or kind of if the HHR again positive, we can think of PARP inhibitor CTC.
Dr. Sachin, when do you consider a repeat biopsy in such patient who is like rapidly progressing, not responding? When do you consider repeat biopsy?
This patient is on continuous the same treatment and progressing in the similar sites. And if we have enough tissue at the time of first diagnosis, then we are not routinely doing the second biopsy at the time of progression. If the sites are completely different from the primary, then we plan for the repeat biopsy to check the another subset or another histopathology in these patients. Otherwise, we used first biopsy and do the NGS panel and all other HRR, HRD to find out any positive marker is there, or we can plan treatment accordingly.
All right. Next slide, please. So this patient has been started on lutetium therapy, and meanwhile the NGS report is also available, which was done either at the same time or later, and BRCA is positive. So Dr. Hemant, like you were saying about BRCA, so you agree to this treatment plan, rucaparib 600 mg BID?
Yeah, rucaparib, if BRCA is there, we can give rucaparib in second line. So I think it is a right treatment.
And if like the report is available to you upfront, when do you add BRCA directed therapy?
No, if it is positive, then I will add with either enzalutamide with um, uh, olaparib plus enzalutamide, yeah, niraparib plus uh, uh, abitral.
Dr. Sachin, you agree to this that we should add upfront with the ongoing treatment or any selection or anywhere? How do you sequence BRCA-directed therapy?
So, if it is available on the day one, then our aim is to treat accordingly. Then we should give ADT along with the olaparib and abiraterone day one we can start with.
I think sounds good that this looks a driver mutation here. So we need to hit this mutation hard whenever available. And next slide, please. And when do you sequence the PSMA therapy, lutetium therapy, Dr. Rohit?
So, sir, if the almost abiraterone and enzalutamide and these hormonal options are exhausted and disease is PSMA positive, then I will go for lutetium, because after lutetium therapy, effect of enzalutamide or abiraterone is not much, or in fact, no effect at all. So, when all of these hormonal therapy with ADT is exhausted, then I'll go for lutetium therapy, sir.
Dr. Sajjan, you also agree that after exhaustion of all the systemic therapy, you consider for lutetium?
So generally, we are doing the same as Rohit is saying. After the exhaustion of the treatment modalities, and if disease is too much and mainly the bony disease is there, then we generally plan for the lutetium therapy.
Right. Dr. Sandeep, any inputs about the lutetium therapy?
Yes, sir.
Any input on lutetium?
Actually, now, yeah, one study, I think we study that if the uh, uh, lesions are more than 80% if the positive for PSMA high positive in this patient, then we should add upfront lutetium therapy. Then we should do lutetium, because, and especially in post-docetaxel treatment, they are very good responder to this lutetium PSMA therapy. So I will not wait for to exhaustion of another treatment if this is highly positive and more than 80% lesions are positive for PSMA positivity, high positivity. Then I will add this lutetium upfront after docetaxel.
So Sandeep, one a request from all of us that this is not yet included in the RGHS. So we request you to expedite somehow if you can help, not related to our discussion, but since you are the most powerful amongst all of us, so I request you to I am feeling that very few patients are deserving for this particular treatment, and many of them have good quality of life. So
Yes,
if
yes.
this can be
And Ma Yojana also.
you understand the logistics better. Next slide, please. Asim is also making that they are using wrong.
Sir, actually, you actually pointed out the purpose of the discussion. Actually,
No, this is
this is the common gain
In
which
the
we can.
indirect direct way.
सर को हर पैनल डिस्कशन में बुलाना पड़ेगा.
संदीप को मिलना बहुत मुश्किल आ जाता है ऑफिशियली सो whenever he is coming to meet us we try to put something important जो हमारे दिल की बात है वो बोल देते हैं चाहे वेबिनार हो चाहे सेमिनार हो. So this is about the post rucaparib that we can see 6-8 months the disease is again progression. This is what has happened with lutetium PSMA therapy. Next slide, please. So this is now progression, and now the treating doctor is considered for cabazitaxel. So Dr. Hemant, you feel this is right or cabazitaxel should have been used before the PSMA therapy or any rationale?
I think no head-to-head comparison, any studies. So we have to choose according to patient's need. So we do not have after lutetium therapy. So I think when patient is very young, so we can also try this cabazitaxel.
I think one actinium therapy is also available in India. Of course, most centers do not practice due to the logistic issues, but after failure of PSMA, that can also be attempted. Next slide, please. So I think we have finished case one, and can the organizers tell us that should we go ahead or our time looks over? We had been given 20 minutes and we
Yes,
have
sir.
4 5 minutes. So I think we stop here in the interest of time. And
Yes,
I,
sir.
Dr. Asim Samar, I thank all my learned panelists, Dr. Jasuja, Dr. Himandadish, Dr. Rohit, Dr. Sachin, for excellent inputs and great learning opportunity. Thank you so much. And with this, we end up the first panel discussion. Thank you so much.
Thank you so much, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you. Thank you, sir. So now I would invite our next speaker, Dr. Mukesh Rolania. So he will be speaking on the paradigm shift in the management of the MIBC. And Dr. Mukesh Rolania is assistant professor and in medical oncology department and hematology department in the State Cancer Institute, SMS Hospital, Jaipur. So he will be speaking on the MIBC topic, and the session is sponsored by AstraZeneca. So Dr. Mukesh. Yeah.
Thank you, Samar Bose. My slides are visible.
Yes, yes. You do full screen and then share, I guess.
So, thank you, Samar Bose, for giving me this opportunity. I will speak on management of muscle invasive bladder cancer in next 20 minutes. So, as you know, global burden of bladder cancer is rapidly increasing, and majority of cases are localized, but some patients have regional disease and some have distant metastasis. This is 9th most diagnosed cancers and 13th leading cause of cancer death worldwide. So coming to prognosis, as we know, stage is according to stage. There's a carcinoma in situ, then non-invasive papillary carcinoma. Stage 1, no, tumor invades suburothelial connective tissue. This is known as NMIBC. Coming to MIBC, which is considered stage 2 and beyond. And third is stage 4, which is metastatic bladder cancer. So what is the current treatment for this muscle invasive bladder cancers? Surgery is a removal of the bladder or adjacent structures, as well as reconstructive techniques to compensate for the loss of structures removed during surgery. Sometimes radiotherapy is used in selected patients who are in where the bladder can be preserved or who are ineligible for or unwilling to undergo sometimes. And sometimes it may be also used as a palliative. Chemotherapy may be administered as a neoadjuvant or maybe as an adjuvant settings. And the aim of the chemotherapy to enhance the clinical benefit of surgical treatment. So how we select various type of therapies in these muscle invasive bladder cancers? Radical cystectomy, all any MIBC patients, and outcome of this radical cystectomy is 50% cure rate with surgery alone and highly dependent on pathological stage also. Bladder sparing partial cystectomy, only feasible when solitary tumors in dome of diaphragm, and outcomes are variables, highly dependent on patient selection. Bladder sparing chemoradiations, when there is no CIS, no hydronephrosis, maximal QRBT required. Outcome 65% cure rate, 55% bladder intact, and highly dependent on patient selection. If using neoadjuvant cisplatin-based chemotherapy, cisplatin eligible MIBC patients, then it's approximately 10% improvement in overall survival compared to radical cystectomy alone. And if using adjuvant cisplatin-based chemotherapy, then similar improvement at the neoadjuvant treatment, but data are less robust and many patients not suitable for adjuvant treatment after surgery. So radiotherapy or chemoradiotherapy may be used in selected MIBC patients, as I already discussed. Patients who are required organ preservations which are ineligible for cystectomy, patient who does not want for cystectomy, and sometimes as a palliative intent. So this is NCCN guidelines for treatment of muscle invasive bladder cancer tumor which have clinical T2 and beyond. Then this is staging workup, and then neoadjuvant cisplatin based combination chemotherapy or perioperative sandwich immunotherapy with neoadjuvant cisplatin combination chemotherapy followed by radical cystectomy, which is category 1. Following cystectomy, if cisplatin gemcitabine is durvalumab, if you utilize initially, then we consider this combination. And based on pathology list, if no cisplatin neoadjuvant treatment given on and T3, T4A and not positive, then adjuvant cisplatin based chemotherapy should be discussed. And adjuvant nivolumab and pembrolizumab is also approved in after radical cystectomy. So patients who have clinically stage 3A, T3, T4A and T1 to T4A N1 disease, again then staging workup followed by neoadjuvant chemo with or without immunotherapy followed by radical cystectomy. And some patient bladder, if require bladder preservation with concurrent chemoradiation with maximal TURBT. So coming to radiotherapy versus chemoradiation in bladder tumors, this study shows that if we adding chemotherapy, there is definitely improvement in local regional disease-free survival and overall survival. And there is during treatment, grade 3 and 4 adverse events are slightly higher with chemoradiation as compared to radiation alone. Bladder intact discharge metastasis-free survival at 3 with chemoradiation is higher as compared to radiation alone. And the author of this study concluded that both regimens are promising. As there was less toxicity in GD arm, it would be reasonable to consider gemcitabine and cisplatin-based regimens for future trials. Coming to neoadjuvant and adjuvant chemotherapy in bladder cancers, if we know that cisplatin-based neoadjuvant chemotherapy is the recommended regimens for muscle invasive bladder cancers, and these regimens provide approximately 5 to 8% survival benefit versus no NACT. Coming to adjuvant, given post-surgery cystectomy patients with extensive disease, MIBC patients who have not received NACT and have no non-organ confined disease at radical cystectomy may be treated with adjuvant cisplatin-based chemotherapy. And patients who are cisplatin ineligible patients, some guidelines say that there is insufficient evidence for non-cisplatin-based adjuvant chemotherapy. So there's a various treatment regimens for neoadjuvant cisplatin gemcitabine or DDMAC. Other cisplatin-based NAC regimens, MVAC and CMV regimens, which are inferior as compared to cisgem and DDMAC. So these studies for which are comparing MVAC versus GC, and this shows the overall survival is little bit higher with GC after 7 to 8 years. Cumulative recurrence in overall populations is again is less with GC regimen, and cumulative recurrence in lymph node positive patients, then definitely there is less recurrence in GC regimen. So toxicity related mortality was higher with MVAC regimen versus GC, 3% versus 1%. And as well, neutropenic fever is also higher and mucositis are also higher. So definitely side effect profile is higher with MVAC regimen as compared to GC regimen. Coming to efficacy, PFS benefit, again PFS is higher and OS is also higher with DDMAC. DDMAC provides patient with the same dosage in a shorter cycle of MVAC versus traditional MVAC every 2 weeks versus 4 weeks. So GCSF is mandatory with DDMAC because otherwise treatment delay will occur in many number of patients. So toxicity related mortality was 4% with MVAC as compared to 3% for DDMAC, and neutropenic fever incidence rate is 26 versus 10% because of utilization of GCSF. And coming to 20% of patients had grade 3 and 4 WBC toxicity with DDMAC, I would say 62% on MVAC. So this study which compare DDMAC versus GC in neoadjuvant settings, patient included only with T2 and beyond. Neoadjuvant DDMAC 30 mg per minute square methotrexate, vinblastine 3 mg per minute square, doxorubicin 30 mg, and cisplatin 70 mg per minute square every 2 weeks for 6 cycle, and gemcitabine for 4 cycles. And primary endpoint of the study is 3-year PFS. Secondary are response rate, OS, TTP, and toxicity. So coming to this neoadjuvant DDMAC versus GC. So DDMAC is better as compared to GC. Coming to OS, again, DDMAC is doing better in all aspects. They are utilizing neoadjuvant all patients. So what is the cisplatin ineligibility? Patients who have performance status 2 and beyond, patients who have grade 2 and more peripheral neuropathy, patients who have eGFR less than 60, patients who have grade 2 or more than 2 audiometry loss, or NYHA 3 and 4. So these patients, there is no standard of care alternative, and a high unmet need exists in these patients. However, following radical cystectomy, some patients may be able to receive cisplatin-based chemotherapy in the adjuvant setting to enhance post-operative survival care. So some patients require adjuvant, some require neoadjuvants. So chemotherapy is administered after accurate pathology stagings. Therefore, treatment in patients at low risk for micrometastasis is avoided in some patients, and no delay in definitive surgical treatment if we are using adjuvant treatments. But disadvantage is assessment of in vivo sensitivity of the tumor is not possible, and all treatment is an unavoidable problem. And sometimes delay or intolerability of the chemotherapy due to post-operative morbidity. That is a disadvantage of adjuvant chemotherapy. So coming to outcomes, approximately 50% of experience recurrence or progression following radical cystectomy within 5 years, and 5 to 8% survival benefit when we using neoadjuvant with radical, and less than half of cisplatin eligible patients receive neoadjuvant chemotherapy. So restricted patient population eligible for ICI. So label for adjuvant ICIs are restricted as patients was shown only in selected patients which have PD-L1 and high risk patients, and no statistically significant OS benefit. At present, we have no OS benefit in adjuvant setting in both neo and pembro trial. So this is first perioperative study, Niagara study, phase 3 study of neoadjuvant DRUA with chemotherapy followed by radical cystectomy, and then adjuvant durvalumab in muscle invasive bladder tumor. They have double arm, durvalumab cisgem versus cisgem. Durvalumab utilized 4 cycle during chemotherapy neoadjuvant setting, and then 8 cycle after surgery, 1500 mg every 4 weeks. And primary endpoint of this study is EFS and PCR, and secondary endpoint is OS. So baseline characteristics. Coming to baseline characteristics in this study. So all parameters are well balanced. Some are highlighting that renal function, which have poor in durvalumab arm in 19 and versus 18 in this radical cystectomy population, and durvalumab is comparator arm in 19 versus 19. So again, both group of patients are included equally in this study. Coming to regional lymph node, majority of patients are N0 and some patients are N1 status. So coming to safety efficacy point of this Niagara study. So as this curve shows that EFS at 1 year is 76 versus 70, at 2 year 67 versus 60, and hazard ratio for PFS is less than 0.001, which is highly significant. Coming to OS, 2-year OS is 82 versus 75, and hazard ratio 0.75, p-value is 0.0106. Coming to final analysis, that shows that PCR rate is approximately 33 versus 25%, and in reanalysis April 24, PCR is 37 versus 27, almost 10% difference of PCR if we are using durvalumab in perioperative setting. So PCR rate, according to PCR status, EFS at 2 year If patient achieved PCR, then 92 and 85. And if patient does not achieve PCR, then EFS is significantly dropped 53 versus 49%. So there is a definitely role of PCR in this Niagara study. Coming to PCR and survival, overall survival. If patient achieved PCR, then survival is greater, 95 versus 91. And if patient does not achieve PCR, then his survival significantly
Dr.
dropped.
Mukesh, sir, sorry to interrupt you. We request you to please conclude in next 2 minutes.
Yes, madam. Yes, madam. PCR rate again 42 versus 30 already discussed. This is risk of DFS higher with DRUA with CGM. PCR and non-PCR again in higher with PCR. Coming to safety profile is well balanced, except only with immune-related some side effects. So coming to conclusions, Niagara study demonstrated statistically significant and clinically meaningful improvement in OS, and we may definitely see OS benefit in near future. Improved PCR rate, which is higher, reduced risk of recurrence or death after radical cystectomy by approximately 31%, and DFS benefit across all pre-specified subgroups and in PCR and non-PCR subgroups. And patients with borderline renal function showed improvement in PCR and AFS with perioperative durvalumab with a similar safety profile to the overall study populations. And this additional analysis from Niagara provides further support for perioperative durvalumab with neoadjuvant CGM as a new treatment for patients with cisplatin eligible muscle invasive bladder cancer. Thank you.
Thank you, Dr. Mukesh Rulania. Thank you for your nice talk. And now we will proceed for the next talk, which is being delivered by Dr. Rohit Swami. Dr. Rohit Swami is consultant medical oncologist in Narayana Multi-Speciality Hospital, Jaipur. And Dr. Rohit will be speaking on maintain to extend, the right approach for maximizing overall survival in metastatic urothelial cancer. So this is again a sponsored session by Mark. So Dr. Rohit, over to you.
Good evening, sir. And first of all, thank you and Mark for giving me this platform to give this speech. Sakshi, please, can you share my slides? Yeah, so I'll be discussing about right approach to maximize overall survival in metastatic urinary carcinoma. Next slide, please. So if we see milestone in treatment of metastatic urinary bladder carcinoma, so in 1980, it was found that cisplatin is the most effective drug in the urothelial carcinoma, and since 1980, almost till 12 years, it was after 12 years in 1992, it was found that the combination of gemcitabine and carboplatin gives survival benefit as compared to cisplatin alone. So median survival was 12.5 months of the combination as compared to 8.2 months with the cisplatin. And then after 1992, for the 3 decades, for the 30 years, not much of the new improvements were done in the treatment of metastatic urothelial carcinoma. Only a few drugs came, pembrolizumab and atezolizumab in the patients who were cisplatin ineligible. And most of the treatment was managed with the chemotherapy alone, either with the GemCis or MBAC or DDMBAC. And even the several studies to combine multiple drugs or 3-drug regimen were also used to improve the survival, but all of these studies failed to show any significant benefit. But in 2020, there came a maintenance therapy after the induction with the cisplatin or carboplatin-based platinum-based chemotherapy. So it was avelumab as a first-line maintenance therapy after any kind of response with the platinum-based therapy and showed significant survival benefit with median overall survival of 23.8 months as compared to 15 months. Next slide, please. So Javelin Bladder 100 was a phase 3 study which compared the avelumab maintenance as compared to best supportive care in the patients of the metastatic or locally advanced urothelial carcinoma after having CR, PR or stable disease with the standard a platinum-based chemotherapy. These were randomized into 1:1 fashion, and primary endpoint was overall survival in all the randomized patient as well as PD-L1 population, and then secondary endpoints were PFS, overall response rate, time to response, response duration. These patients were further stratified according to the response to first-line therapy as well as site of metastasis. Next slide, please. And in the exploratory post-hoc analysis of overall survival from the beginning of the first chemotherapy till the progressive disease, median overall survival was around 29.7 months in the avelumab arm as compared to 20.5 months only in placebo arm. So it was a significant benefit in median overall survival. Next slide, please. And this survival benefit was maintained in all the subgroups, whether the patient received cisplatin or carboplatin, whether patients received less than 15 weeks of chemotherapy or more than 20 weeks of chemotherapy, whether the response was complete response or stable disease, or whether the treatment-free interval length, that is randomization, was within 4 to 10 weeks of completion of chemotherapy. Next slide, please. And if we see long-term safety of this study, even the patient who had received more than 12 months of avelumab, the phase 2, 3, phase 3, 4, or any kind of adverse events frequency decreases as the avelumab maintenance goes beyond the 12 years. Like we can see that all the treatment-related adverse events were not much in the patient who were receiving this avelumab continuously even after the 12 months as compared to the patient who discontinued it early because of progressive disease or some other reasons. And the most common adverse events which were uh, noticed in the patients who received avelumab for 2 years or more than 2 years was mainly pruritus, hypothyroidism, fatigue, asthenia, loose motion, infusion related reaction, which are mainly avelumab related side effects. Next slide, please. But the patient who received avelumab for more than 1 year, the median PFS reached up to 26.7 months with median overall survival not reached. So around 47% of patients in this trial received avelumab for more than 6 months, 28% more than 12 months, and after I think 1 year of the maintenance avelumab, we select those patients, those 20 or 25% of the patients who are going to do very well with the avelumab maintenance. Like the patient who received more than 2 years of avelumab were around 20% as compared to 28% which received for only more than 12 months of avelumab. Next slide, please. And this overall survival data keep on, I will say median overall survival or overall survival probability keep on increasing as the patient receives the avelumab maintenance for the much and much longer time. Like for the patient who had received avelumab for more than 2 years, 1.5 year overall survival probability is 90.3% as compared to 80% in those patients who had received it 1 year or beyond, not reached up to 2 years. So, and also no new safety concerns were identified with the long-term treatment duration and the patient experiencing any treatment related adverse event for 1 year or more than 1 year was 50%, more than 2 year was 35.5%. So it is not such like that longer the exposure of the drug, more is the side effect. Next slide, please. So in 2020, we got avelumab, which gave us the survival benefit after induction with the cisplatin-based or carboplatin-based chemotherapy, and then we have two more lines of therapy along with us. So first was the first line EV plus pembrolizumab or first line gem-cis or nivolumab combination as per CheckMate 901. And another option was after progression on chemotherapy, induction chemotherapy, avelumab maintenance to go for EV. And then adafitinib also showed us that there can be a survival benefit in some patients. So till 2023, we have 3 to 4 more options. Next slide, please. So CheckMate 901 study strictly enrolled the patient who were cisplatin eligible, and these patients were then randomized into 1:1 patient to gem-cis nivolumab or gem-cis, and the patient were then continued on the maintenance nivolumab for till the disease progression, or at least for the 2 years. Primary endpoints are overall survival and PFS. And the thing is that in the arm where only GEMSIS was received by the patient, there was no maintenance, or only 11% of patient received maintenance of avelumab. This trial showed median overall survival of 21.7 month in the nivolumab arm as compared to 18.9 month in the chemotherapy arm. So if we see numerically, so median overall survival benefit of only 2.8 month and PFS benefit of 0.3 month as compared to GEMSIS, though these were statistically significant. Next slide. And if we see frontline EV plus pembrolizumab, so it showed very significantly good results. Endpoints were again PFS by BICR and overall survival, and there was doubling of PFS as compared to chemotherapy alone. So 1 year PFS probability was around 51.4% as compared to 21.7%, and overall survival probability of 1 year was around 77.7% as compared to 61.1%, with the median overall survival of 33.8 as compared to 15.9. So almost double median overall survival. So 32.2% patient in the GEMSIS arm in this study also received avelumab maintenance, but still 100% of them didn't receive avelumab maintenance. So next slide, please. But the problem, as we all know, using EV is not as easy as using avelumab. EV 302 and 103 pooled safety data analysis showed that there are few concerning side effects with the EV. First is the skin reaction, and the patient who experienced skin reaction were around 328, out of which 58% had only complete resolution, 42% had some kind of residual skin reaction, and even 40% had more than two grade skin reactions. But on the other hand, another debilitating side effect is neuropathy, which is complete, which is residual neuropathy in 90% of patients, whether grade 1 or grade 3. But having 90% of residual neuropathy is quite toxic for the patient, and 50% of these patients had residual grade 2 neuropathy. Next slide, please. So, though EV was initially proposed that can be used in the cisplatin ineligible patient also, but European Oncology Guidelines has issued a EVETA guideline for ineligibility of EV, and this includes generally the patient of poor performance, or patients with poor glycemic control, renal clearance less than 45, any corneal retinal abnormality, or any kind of grade 2 or more than grade 2 neuropathy. And I think these should be followed because these patients may end up in the trouble with the serious side effects because of EV. Next slide, please. So if we see all patient population to be treated, Javelin 100 takes all the 100% of the patient, treat them with the GEM-CIS or GEM-CARBO, and since cisplatin eligibility is not a criteria for the Javelin 100, even patient with the GEM-CARBO can receive avelumab maintenance. So around 90% of patient receives maintenance therapy. Similarly, in nivolumab study, since cisplatin eligibility is a strict criteria, around only 50% of the patients are able to receive nivolumab and nivolumab maintenance. And EV302, after this EVITA criteria, I will say around 15 to 20% of patients will not be able to receive EV302. Next slide, please. Now coming to real world evidence, so what we can learn from the real world evidence data, whether the PFS and survival benefits seen in the control setting can be reproduced in the real world scenarios. So next slide, please. Global real world evidence for avelumab is there throughout the world. We had studies from the America, South America, Europe, as well as Asia Pacific. Next slide, please. And as per the Javelin study, median PFS was around 5.5 months, and median 12-month overall survival rate was around 71.3%, which was consistent, almost consistent in all of these real world studies. and some of the real world studies doing much more, going to the PFS of even 11 months, and overall survival percentage of 79.3%. Next slide, please. So similarly, median overall survival after starting from the first line of chemotherapy till the disease progression, real world studies has showing the data similar to Javelin study, where Javelin study median overall survival was around 30 months. Some studies are reaching even up to 38.9 months, which was a Japanese JAV study. Next slide, please. And even Indian real-world evidence on avelumab maintenance is also consistent with the randomized Javelin study, as well as global real-world evidences with median PFS of around 5 months. And in the patient who had received avelumab for more than 6 months, median PFS was 11 months. And median overall survival was not reached, and 12-month overall survival rate was around 82.1%. Next slide, please. And if we see real world evidence study of EV plus pembrolizumab in the first line, so it is almost not matching as was shown in the study. Like in the Unite study, overall response rate was around 54% only, and 12-month overall survival was around 67, whereas the RCT so shows that in the 303 that a 12-month overall survival probability is around 78.2 months with a response rate of around 67.7 months. Though several other real-world evidence studies will come and will further support this EV plus pembrolizumab in the first-line setting. So overall response rate and 12-month PFS OS rate were comparatively low in real-world
Dr. Rohit,
evidence
sir,
studies.
sorry to
Yeah,
interrupt you. We request
completed
you
all,
to please.
already
Okay.
completed.
Sure, sir, sure.
So sequence of therapy. So percentage of patient who can receive the next line of therapy after chemotherapy and avelumab maintenance is around 75.6%. Even in the real world studies, around 82%, and percentage of patient after receiving EV and pembrolizumab is much lesser as compared to chemotherapy followed by avelumab maintenance. Next slide, please. Next slide. Next slide. So this slide shows that after avelumab maintenance, if we go for EV, then we can reach up to the median overall survival of 40 months or more than 40 months in most of these studies as shown. Next slide, please. So first line maximum, I'll say median overall survival 33.8 months with the first line EV plus pembrolizumab. But if we go with EV after progression of avelumab, we can go beyond the 40 months of median overall survival. Next slide, please. So we are familiar with all of these three studies, and we have seen that there is PFS as well as survival benefit with all of these three studies. But how to uh, sequence these therapies? So it appears to me and most of the people that the well balanced way is to go with the chemotherapy followed by immunotherapy maintenance, and on progression to go with EV. Thank you everyone.
Thank you, Dr. Rohit, for delivering a nice talk, and you finished in time also. So thank you very much. And now I would request Dr. Anant Ramaswamy, a dear colleague from Tata Memorial Hospital. He is a professor in Department of Medical Oncology, and especially he is seeing the GI cancers. So Dr. Anant will be speaking on advancing GI oncology, changing landscape in the CRC, colorectal cancer. So over to you, Dr. Anant.
Thank you, Dr. Asim. Am I audible?
Yes, yes.
Okay, so I'll just share my slides if it's okay. Are my slides visible?
Yeah, correct.
Okay, great. So at the outset, I'd like to thank Dr. Asim and the organizers for inviting me to the CME. Over the next 20 minutes, and hopefully I won't overshoot time, I'll try and cover these 5 topics and my thoughts on the changing paradigm with respect to these 5 topics. So the first thing is in resectable colon cancers, we were always taught that it is surgery followed by adjuvant therapy, but this paradigm is probably changing. Over the last 4 to 5 years, we have 4 randomized studies which have said that maybe giving chemotherapy first is a reasonable option. Now, majority of these studies, and there is a meta-analysis to suggest which has looked at this in close to 2,100 patients in mainly T3, T4, and N0 to N2 tumors. And they say that if you give neoadjuvant chemo first, which is standard FOLFOX or CAPOX, you actually have higher R0 resection rates. But the caveat with this is that around 5% of patients may not go on to surgery. But if you look further, the important thing is that if you give neoadjuvant chemo first, then especially in patients who are proficient MMR, you almost have a 32% risk reduction in terms of DFS and almost 40% risk reduction in terms of overall survival. Now, these are very impressive numbers, but if you look at how practice has gone over the last 3 to 4 years, most of us are not comfortable using neoadjuvant chemotherapy prior to surgery in resectable colon cancers. Now, the issues with this are that one, patient selection is very crucial. We depend very heavily on radiology and PET scans for staging, and there are significant issues with under as well as overstaging in stage 2 and 3 cancers with a CT or a PET. And this is where the role of an MDT is crucial. What I would suggest is that in very early stage 3 cancers, which are T3, N1, probably resection followed by adjuvant is very good. In case you have a deficient deficient MMR cancer, it's preferable to avoid chemo. The best kind of patients for this approach would be those who have T4 or T4B cancers. And in those patients where you feel that your surgeon feels that an extended resection is probably needed, probably it's a good idea to give neoadjuvant chemotherapy first. Coming to the MSI high cancers, I think this is where the role of neoadjuvant therapy is probably the evidence is best, and we would also be comfortable doing it. There are 2 studies in this area. One is the small niche study, which looked at 115 patients, gave only 2 doses of immunotherapy, and you had almost 70% pathological CR rates. It's important to note that a lot of these cancers were T4 and node positive. The other study, the full paper, which has not yet come, is the atomic study, where you operated patients with deficient MMR cancers and then gave them FOLFOX and atezo and 6 months more of atezo. Now, obviously, this is like comparing apples and oranges. You cannot compare a small phase 2 trial with a large phase 3 trial. But if you look at these 2 curves, the curve on the left is for the atomic trial, where you had to give 1 full year of immunotherapy and then you achieved a 10% improvement in DFS. Now, if you look at the curve here, which is for on the right, which is for the niche study, no patient had progression after immunotherapy, and the degree, almost all of them had some kind of response, and 70% had a pathological CR. So the question remains is that we should now do an MSI in all our patients with colon cancer. These cancers are exquisitely sensitive to immune checkpoint inhibitors. We should not do cross-trial comparisons, but we are all doing it. The question is that while Atomic was a phase 3 study, do you really need large studies to prove the efficacy of immunotherapy in MSI high tumors? That is the question we all have to ask. If you look across solid tumors also, a majority of the benefits are with immune checkpoint inhibitors are in the neoadjuvant setting as opposed to the adjuvant setting. So till the time we have a longer follow-up and slightly larger numbers, in early tumors which are MSI high, T3, N1 or so, probably the niche approach is very good. In those who have slightly heavier burden of disease like T4N2 or T3N2, we need to discuss this in an MDT whether such patients would benefit with a niche 2 approach or an atomic approach. But the key point is that we should be doing an MSI and we should think of immunotherapy in this setting. The other major change that is emerging in colorectal cancers and probably all solid tumors is the ctDNA. We have gone from physical exam to CT scans to PET scans to CEA, and probably the most sensitive marker we are now having in our hands is ctDNA. And a lot of good data has emerged over the last 5 years with respect to ctDNA in colon cancers. As we all know, there are two different approaches to this. One is a tumor informed and the other is a tumor agnostic. I won't go into details, but there is some evidence to suggest that maybe a tumor informed approach is slightly better. Now, we have been traditionally always looking at factors like TN, LBI, PNI, location, etc., when we plan our adjuvant therapy. But if you look at the data for ctDNA, and I've highlighted the p-values and the hazard ratios here, a positive or a negative ctDNA post-surgery roundly beats all the traditional prognostic factors. The hazard ratios for ctDNA is 12, while for all the others it is only 1 to 2. So now there is enough data to suggest that a ctDNA value post resection, and if you have two negative or two positive values, then it is definitely prognostic, and there is almost no doubt on this. Just to show that, I've showed the curves from the bespoke study, which was presented at ASCO 2025 GI. Now, the curve on the left is for stage 2 cancers, while the curve on the right is for stage 3 cancers. You can clearly see that ctDNA negative patients after surgery do really well. It's almost like a straight line. While those who are ctDNA positive, clearly the DFS is less. The next thing is that, so what if your ctDNA is positive? If you give adjuvant therapy, does that help? Yes, it does. So with the help of adjuvant therapy, you can, probably reduce your risks of recurrence. It is not 100% reduction in risk of recurrence, but if you have ctDNA positive and you give chemo, you probably improve survivals as opposed to having ctDNA positive post-surgery and not giving chemo. So ctDNA is probably predictive of some degree of benefit with adjuvant therapy. The question is that while the data for ctDNA is very strong in terms of prognostic ability, what do you do with it besides giving adjuvant or not? Can you use the ctDNA levels to either escalate therapy or de-escalate? So if you have a ctDNA negative value, can you de-escalate therapy in terms of no adjuvant, or instead of giving Capox, you would only give Cape? And conversely, if you had ctDNA positivity, would you consider escalation of therapy from, let's say, capecitabine to Capox, or Capox to even FOLFIRINOX? So this is the final paper of the Dynamic 3 study, which has been again presented over the last 1 year. I won't go into full details, but it is one of the largest studies in this. They randomized almost 900 to 1,000 patients, and they treated ctDNA positive patients with either escalation or standard, or ctDNA negative with escalation or standard. The points that we need to remember from this study, and it's a fairly well conducted study, is that it once again proved that if you were ctDNA negative, then you definitely did better than ctDNA positive. But if you are ctDNA negative and you consider de-escalation, the primary endpoint of the study, that was non-inferiority, was not met. Similarly, if you are ctDNA positive and you escalated therapy, that also did not improve outcomes over standard management. So while the study clearly highlights the prognostic value of ctDNA, escalation or de-escalation based on ctDNA negativity or positivity still has not been achieved. So on ctDNA itself, I think we should all accept that it is a very strong prognostic marker. But current approaches to escalation or de-escalation based on chemotherapy alone, the evidence is not there yet. The probable way to go forward is either have larger studies, or if you had a target on your NGS and using that to escalate or de-escalate, would that help? Future studies will probably tell us. But ctDNA as a tool is probably here to stay. Coming to the metastatic setting, BRAF mutants, they constitute around 5 to 8% of all our patients with metastatic colorectal cancer. They're a tough cohort to treat with available treatment options, which was chemo. Survivals barely crossed 12 months. It is both predictive and prognostic. Important to know that not all BRAF is bad BRAF. The bad one is V600E, while class 2 and class 3 mutations don't have such a negative effect on or prognostic effect on outcomes. This is data from earlier, which clearly shows that if you have a non-V600E mutant, you do as well as wild type almost, while those who have a V600E, you really do bad, and very few people cross 1 year. So the big change in this group of cancers has been the breakwater study, where they looked at adding encorafenib, cetuximab to FOLFOX. And this was quite a large study in a cancer which has only 8 to 10% of all metastatic colorectal cancer patients. So they looked at encorafenib, cetuximab, and FOLFOX, as well as standard of care chemo in more than 600 patients. And very impressively, the PFS was almost doubled. In the experimental arm, it was almost 13 months compared to 6.5 to 7 months in chemo and encorafenib cetuximab. And the most impressive bit is that the overall survival was 30 months. Now, this overall survival has not been heard of in BRAF mutant cancers previously. For those of us who treat colorectal cancers, crossing 1 year was tough. So definitely a game changer. But it does come with its share of caveats. Almost 1/4 of patients who are getting the combination will have to stop therapy because of toxicities, and the toxicity rates almost double compared to standard chemo, but definitely a game changer. So the major issues with this approach is that encorafenib is still not available, and the available combinations, other available, which have looked at vemurafenib or dabrafenib, have not shown very good results. And of course, the toxicity is a problem, but when and if possible, we should consider the use of this combo, though it is almost prohibitively expensive as of now. Next up is the RAS. So traditionally, we have always thought of RAS-directed therapy in terms of the first-line therapy. We do know that if you have a left-sided metastatic colorectal cancer, largely you would give chemo plus an anti-EGFR therapy, while almost always in a right-sided cancer, you would use chemo plus bevacizumab. So I won't go into this. It's important to know that even 15 to 20 years back, in patients who have progressed over 2 lines of therapy, that is oxaliplatin-based chemotherapy and irino-based therapy, you could use cetuximab or panitumumab alone. And this was approved based on studies in 2007 and 2008. But the benefits with this approach of using monotherapy was in the range of a few weeks to a few months, which is not a great idea when cost is an issue in our country. So probably the best way to use them is based on this paper by Santini, where they said that if you give anti-EGFR directed therapy first and then had an anti-EGFR free interval, you could probably re-challenge with anti-EGFR because the RAS wild type clones increase in the gap period while the RAS mutant clones decrease. And since we now have liquid NGS, current approaches use this. This was the nicely named cricket study, again published 4 to 5 years back, where in patients who were initially RAS wild type, you gave them chemo plus anti-EGFR, then give them chemo without anti-EGFR and probably Bev. And then as third line therapy, you gave them irinotecan plus cetuximab. Now, the important thing to note here is that at post 2 lines of therapy, those who was RAS wild type by liquid biopsies and ctDNA had much better survivals. So the learning point here is that if when patients are approaching third line therapy, it's a good idea to do ctDNA to look for RAS status and only use anti-EGFR directed therapy if you continue to be RAS wild type as opposed to RAS mutant. Now, there are a number of phase 2 studies and retrospective studies which have said that you can have outcomes between 8 to 12 months if you use anti-EGFR directed therapy in this way. So RAS wild type going to RAS wild type in third line therapy. The newest kid on the block is something called NeoRAS, which is slowly emerging. So what the NeoRAS says is that if you are RAS mutant at baseline and you're exposed to chemo and Bev, etc., a fair number of patients actually end up being RAS wild type after some time. And there are a number of small studies and case series which have looked at this particular question over the last 4 years. Now, if you look at the extreme right, I've highlighted what proportion of patients are initially RAS mutant and turn to be RAS wild type. Now, some of these numbers are very high, 40%, 78%. The largest studies, though, say that this phenomena is seen to 10 to 20% of patients. So from RAS wild type to mutant to back to RAS wild type, we are actually looking at mutant to wild type. And of course, this is early data only. And some of the reasons for this that are considered is that chemo probably has a greater activity on RAS mutant clones. Bev might have some greater activity on RAS mutant clones. Of course, the most important thing to note is that we need to maintain a single method of assessment, and NGS, PCR, they all have different sensitivities. So this is only an emerging concept. But because of these concepts of NeoRAS and RAS rechallenge, instead of regorafenib and TAS-102 Bev, we now have more options which can be considered based on these approaches. So if you're looking at third line treatment options, it's a good idea to look at liquid NGS and only those who
Dr.
are.
Anand, sir,
Yeah.
sorry to interrupt you. Please conclude in next 2 minutes.
Yeah, sure. So looking at RAS wild type is a good option here. And the concept of NeoRAS is emerging, but we need more numbers. To the last bit of my presentation, we all know the Keynote 177 data, which showed that pembrolizumab was effective in MSI high cancers. Of course, the overall survival was not significant because 60% of patients in the comparator arm received second-line treatment. But there was a concern that approximately 20% of patients in the pembro arm actually, had remarkable progression. But that is where the Nivo plus EP data comes in. This was again over the last 1 year, multiple presentations have been made where Nivo plus EP has been compared to nivolumab. And this is the overall survival data. It is still immature, but after a median follow-up of more than 4 years, the OS difference is around 13% when you give Nivo plus EP compared to Nivo alone. And if you look at the initial part of the curves, the dip in survivals is not as much with Nivo EP as it is with Nivo alone. Of course, side effects are more with the combo, but that is only to be expected when we give ipilimumab. For a majority of patients, we cannot afford immunotherapy. We have some data from TMH where low-dose immunotherapy has shown quite good outcomes, although these are very early outcomes. So my thoughts are that if you can use the dual immune checkpoint inhibitor, please use it. The worry about early progression probably is resolved if you use dual checkpoint inhibitors. You need to keep a watch on IRE. For those of our patients who cannot use dual checkpoints, do consider low dose immune checkpoint inhibitors. MSI high cancers are very sensitive to this, and in 1 to 2 years, we'll have data from a phase 2 trial from TMH also. With that, I'd like to thank you for your kind attention. Thank you so much.
Thank you, Dr. Anand. It was a lovely talk, and I learned many new things and your thoughts of the ctDNA and dual checkpoint inhibitor. So it was a nice talk. Many of the things you have actually inculcated in your practice also, but we are still far ahead, far behind from you. So we are not looking at ctDNA. We are not challenging with the double in the NACT setting, the immunotherapies and all that. But it's good. Yeah, we can change our practice, or at least we can counsel the patients and relative. This is the emerging modality. If you want to go for it, go in the neoadjuvant setting. And the waterfall plot which you have shown in the presentation was wonderful. So hopefully we will be in the practice like this. So thank you very much for giving this
Thank you,
nice talk.
Asim. Thank you.
Thank you. Thank you. So now I would request the next presenter of this meeting, Dr. Abhishek Sharma, our dear colleague, and he is the consultant medical oncologist in Goyal Hospital, Jodhpur. So he will be speaking on transforming patient outcome in the management of the first line SCC, and it is the sponsored talk by AstraZeneca.
Yeah. So thank you, Atimper, for this invitation, for this academic learnings for all of us. So definitely, I am going to talk about the especially unresectable hepatocellular carcinoma advanced stage, what we have right now in our bag, IO-IA combination versus IO and target therapy. So yeah, can someone share my slide, please?
Sakshi, can you share that? Sakshi, please be attentive because no, sometimes the speaker wants to change and.
Yes, sir. I'm here.
So yeah, can we start? So go with the next slide, please. Yeah. So definitely, we are here for discussing most especially liver cancer patients. So liver cancer is the seventh most common cancer and the most frequent cause of cancer-related death globally. You can clearly see the global incidence as well as global mortality. So liver cancer definitely plays some role as well incidence as well as mortality. So somehow this is the cancer we have to look for the treatment options because when we look at the previous treatment part, there is nothing, the few months survival of the patient, those who advanced stage hepatocellular carcinoma and other liver cancers. But yes, right now we have a multiple treatment options. So we are going to discuss about all of that. So yeah, this is the clear-cut good evidence of the liver cancer, and this is most commonly that incidence that lead to the mortality, yeah, quite high in the liver cancer patients. So now we have to go and discuss about this all. Next slide. So mostly 45% cases. So basically, the disease is basically presented to you in form of localized disease as well as regional disease, distance, and those who are not stages. You can clearly see almost mostly patient presented in the localized as well as regional disease, almost 44% present in the localized disease. And when you look on a regional and distant part, this is around 45% disease regional as well as distant metastatic disease clearly found at your presentations. So almost you can say half of patient present in the localized, half of patient present in the advanced stage. When you look for their survivals, you can clearly see the 5-year survival rates are almost 30% in the localized disease and almost 10% in the regional as well as only 2% in the distant metastatic patients. So yeah, definitely the patient, those who are presented in the advanced stage disease, that prognosis is quite poor compared to the localized disease. Next slide. Yeah. So when we talk carcinoma HCC in India, liver cancer is the 11th most common cancer type and the 8th most common for cancer death. With the SCC is the second most common death in the men. Global 2020 in data, the incidence around 30,000 number of cases, around 36,000 number of cases related to the death. Male female ratio, that is more male prevalence, and the median is around 40 to 70 year, and the frequency increase with the increasing age. The incidence of SCC in serotics in India around almost 2% per year. And you can clearly see the patient most commonly presented in the stage that is BCLC-B and followed by the C. And after that, A is very less common. The most common presentation is the loco-regional as well as the BCLC stage around B and C is the most common presentation we clearly see in our daily to daily practice. Next slide. Yeah. So now, what is the etiology basically behind that? This is most commonly a chronic infection that lead to inflammation that lead to malignancy. The chronic infection in any form that lead to apoptosis by any viral etiology like HBV and HCV. Some metabolic syndrome like NASH, and due to drug alcohol chronic alcohol abuse that lead to the cell death followed to the deregulated liver immune network that lead to the immune suppression that lead to the meshing tumor surveillance that lead to the proliferation and pre-oncogenic transition that lead to the fibrosis, followed by cirrhosis, then dysplasia and development of malignancy. So this is the mechanism of the development of the tumor. And clearly see this is the multiple mechanism of the immune escape and evasion, including overexpression of CTLA4 and PDL1 that inhibit the antigen presentation. So the tumor microenvironment is slightly high immunogenic that definitely major cause of use of immunotherapies and increasing results of immunotherapy in the HCC patient. Next slide. Yeah. So the risk factor in pathogenesis, we already discussed the viral is around mostly hepatitis B and C is involved. Substance abuse is alcohol and some kind of toxin like aflatoxins. NAFLD, NASH, obesity, diabetes, these are metabolic causes and other that is age, gender, sex, male, geography, autoimmune hepatitis that all are lead to the chronic inflammation that lead to the cirrhosis that lead to the hepatocellular carcinoma. So this is a risk factor. This is a pathogenesis we see in the patient. Next slide. Next slide, please. Yeah. So definitely, in the initial days, the most common cause is hepatitis by any cause, especially viral hepatitis, autoimmune hepatitis, and some alcohol cirrhosis that lead to the fibrosis. And but in the recent days, what we are changing in the incident, why the pattern we are seeing, basically a young age hepatocellular carcinoma. The most common etiology of SCC was NAFLD, almost 35%, followed by the viral hepatitis right now. This is the published study in 2023. This is clearly showing NAFLD is right now is a major cause of increasing HCC incidences, especially in the younger population. Next slide. So now we are going to discuss about the management of the advanced and unresectable hepatocellular carcinoma. As we all know, whenever patient presented to us as a clinic. Next slide. Yeah. So definitely, most commonly when patient presented to us, we are definitely randomize patient accordingly, which is localized as well as regional meds as well as distant meds. And after that, the most common classification we use, there are the multiple classification, but most widely and most accepted classification is the BCLC. And after a VCLC classification, you have to stage your patient in very early stage or early stage. You can clearly say single lesion that is amenable for resection, go for resection. Those who are not amenable for resection, definitely, if there is no contraindication to liver transplant, go for just the liver transplant. But in an intermediate stage, that is multinodular, preserved liver function with a good ECOG, definitely extended liver criteria they fit in, definitely go for a transplant. But they are not fit in, then go for a loco-regional therapy in the form of TES or TAR. Followed by if you are going for a successful downstream, then you can plan for transplant. If there is a failure, then you have to use for some systemic therapy. Especially in the advanced stage C, there is a portal invasion, PS1 or 2, extrahepatic spread, preserved liver function. You can plan for systemic therapy. But basically, IO plus bevacizumab, IO combination is the most commonly indicated as a first line, and next is a target therapy like TKIs, regorafenib, cabozantinib, lenvatinib, sorafenib. These are the TKI available as a second or third line in our patients. And definitely terminal stage patient, those who are not fit or any kind of treatment, they plan for the best supportive care in our definitely treatment part. So this is the treatment paradigm we use and follow in our daily practice in the management of hepatocellular carcinoma. Next slide. So this is development of the systemic and advanced treatment in the patient. Initially, when you look for some SARP or reflect trial, the use of the TKI is definitely give some hope to the patient, especially in advanced SCC patients. Their survival in few months, their progression-free survival in 2 or 3 months. After adding this TKI, sorafenib, followed by regorafenib, then lenvatinib, they at least they put some few months in the progression-free survival. They put some month in the progression-free survival. At least patient attest survived to few years with this TKIs. So these are the quite surprising and good treatment part in the especially HCC. Now the in the modern era, definitely IO combination and target therapy with the bevacizumab anti-VEGF and IO combination is the best treatment. And now patient is going to be survived in a few years, especially in the B or C stage patients. Next slide. So definitely, I already discussed about the star effect reflect. They are the comparison of sorafenib versus placebo, lenva versus placebo. You can clearly see their median OS survival, their median PFS survival, response rate is at least present with the 2%. And there is some, when you look at a reflex study, there are median OS as well as PFS survival when they compare to the. So definitely, sorafenib showing some PFS as well as OS benefit compared to placebo in a reflect trial. Lenvatinib showing some PFS benefit, median OS are more or less similar. So modest improvement in the OS and considerable side effect associated with the both treatment underscored the unmet need of the better clinical outcomes in the management of hepatocellular carcinoma patients. Next slide. Next slide. Now come to the picture. Phase third, I am Brave 150. We are going to discuss about atezolizumab and bevacizumab. Same criteria as more or less same trials. Locally advanced or metastatic unresectable HCC. They stratified according to region, ECOG, microvascular invasion, extrahepatic spread, baseline alpha fetoprotein more than 100 or less than 100. They compare sorafenib versus the atezolizumab 1200 milligram every 3 weeks and bevacizumab 15 mg per kg every 3 weeks. Until clinical benefit or unaccepted toxicity, they continue to follow. The primary endpoint is a similar co-primary endpoint, OS and PFS. This is IRF assisted, and secondary endpoint is response rate as per resist and mRECIST. We can say so. Definitely, they are going to be show some benefit in the PFS and OS. Next slide. Yeah. So you can clearly see there is a very well suppression in the both PFS and OS from a starting point. You can clearly 6 month OS, 1 year OS, and 18 month followed by the separation till the 3 year. So there is a quite excellent separation of the curve. Almost 18 month OS is 40 versus 52 month. When you look on a PFS part, 12 month, 12% is the 24% is the 18 month of PFS. So almost doubled in the PFS, almost 15% gain in the OS in an 18 month. When you look for a median OS, that is quite good, 19 month versus 13 month, with the hazard ratio is 0.6 and the significant p-value we can clearly see in the OS as well as PFS part also, and quite significant improvement in the PFS that is statistically as well as clinically meaningful. So yes, there is a good PFS and OS survival benefit we seen in the use of atezolizumab and bevacizumab. Next slide. This is a subgroup analysis. Right now we have a multiple meta analysis also, post-hoc analysis also. We clearly see that any subgroup that is region, that is performance status, that is BCLC stage, viral as well as non-viral etiology. Atezolizumab and bevacizumab doing better comparing the OS as well as PFS compared to the sorafenib. This is forest plot clearly showing benefit of the atezolizumab plus bevacizumab combination when they compare with the sorafenib alone. Next slide. And when you look for a safety data, the most common reported adverse event is hypertension, proteinuria, loss of appetite, and diarrhea. So yes, that is quite comparable, manageable safety toxicity profile we see when we are using first time IO with the anti-VEGF combination. So yeah, this is the, you can say the milestone that started the IO and anti-VEGF treatment in the hepatocellular carcinoma with showing PFS, OS benefit, and acceptable side effect profile. Next slide. So now the picture with the dual IO inhibition, IO combination, as we all know, we have also data of checkmate with the dual IO combination. But yeah, we only found the OS benefit. There is no significant PFS benefit found in this study. But this is the study basically the STRIDE protocol. That's the anti-CTLA-4 inhibitor with the tremelimumab with durvalumab IO combination. We are right now. This is the most uh, uh, discussing topic is the combination in the HCC patients. Next slide. So yeah, rationale for the combination we as all know, anti-CTLA-4 act lymphoid compartment to the increase the number of T-reactive cells, and the anti-PD-L1 act in the tumor microenvironment to prevent T-cell inhibition. So both are combined and enhance the synergistic anti-tumor activity. So this is the rationale behind the dual IO as we all know. Next slide. So durvalumab and tremelimumab increase anti-tumor activity by reversing T cell exhaustion and allowing T cell activation respectively. So tremelimumab blocks CTLA4 allowing T cell activation, and durvalumab blocks PD-L1 that reversing T cell exhaustion. So both are work as a synergistic action that lead to the more number of responses, especially in this kind of tumors. Next slide. Yeah. So this is a very important part of this study design. Tremelimumab blocks suppressive T cell signal in the lymph nodes, while durvalumab inhibits suppressive PD-L1 and PD-L1 interaction in the tumor microenvironment. So the question is that could a single priming dose of tremelimumab and durvalumab improve immune-mediated clinical activity in SCC patient while minimizing the toxicity? So the high dose he combined with the D result in the initial burst of the peripheral T cell in the patient with the non-small cell lung cancer that already discussed. The combination IO when you're using high dose of the CTLA4 inhibitor, so that is basically responsible for the high initial burst of the peripheral T cell in the patients. So similarly in melanoma, the initial dose of ipilimumab and nivolumab causes the proliferation burst of peripheral T cell, which is not repeated as the subsequent doses. So the in solid tumor cancer, immune checkpoint inhibitor regimes incorporating higher doses of the anti-CTLA4 to improve the initial burst of the peripheral T cell in the patients, and the PDL1 are often associated with the improvement in the OA compared to the dose with lower doses of the CTLA4, but with the increased toxicity. So yeah, uh, a single higher doses is a good T cell activation and the minimum toxicity. So it is quite excellently most commonly used regime in solid tumor patients. Next slide. Yeah. So this is the phase second 22 study 22 that evaluates the doses parameter of that. They use the single priming dose of the 300 milligram tremelimumab while the durvalumab 1500 milligram every 4 weekly, and they studies the tremelimumab 75 milligram every 4 week followed by the 12 weeks. So you can say a single high dose versus the subsequent lower continuously lower doses of the both combination, and they do an analysis in the safety as well as OS part. Next slide. Yeah. So you can clearly see the stats show a highest efficacy when they compare the monotherapies of 75 milligram or durvalumab combination. The longest median OS you can clearly see in this arm. Median OS is the highest in this arm, as well as one event was observed around 27 months. When you look for our safety profiles, that is quite safe than compared to the other continuously monotherapy part. So you can clearly say the single high dose of CTLA4 inhibitors is more effective in improved survival, as well as toxic profile more or less similar when you are single high dose versus continuously doses of that. So the most acceptable protocol is that further studies in the further continue to phase third trial Himalaya. So that we are going to be discussed. Next slide. Next slide, please. This is the phase third randomized open label multi-center trial. Inclusion criteria more or less similar. BCLC class BC, no prior therapy, child pug A, and study files more or less similar as a microvascular invasion, other etiology on the basis of the performance status. They are a four-arm that basically start is the same we already discussed versus durvalumab versus sorafimab. And definitely arm D they initially planned, but yes, after the phase second study, they definitely know for this because this clearly shown a single higher dose is best responsible. The primary endpoint is the OS, and secondary endpoints was response rate, PFS, as well as other duration of the response and the CRPR rates. So this is a study we are going to be discuss about that. Next slide. That definitely we already discussed about that. What is the regime and what the subsequent doses we are going to follow in this arm. Durvalumab every 4 weeks, 1500 milligram, but tremelimumab a single dose, 300 milligram we are going to be used. Next slide. Yeah. Demographic and baseline characteristics, you can clearly see there is well matched in the three arm male age, region, and etiology, ECOG, and BCLC classification and characteristic on the basis of LB grade 1 to 3, child pug A and B, MBI present or not, extrahepatic disease, PD-L1 positivity, and AFP more than 100. So you can clearly see in the both part characteristic as well as demographics is well matched in the three arm. We can clearly see. Next slide. Next slide, please. Yeah. And the subsequent line therapy, you can clearly see there is a almost patient who received
Dr.
almost.
Abhishek, sir, sorry to
Yeah,
interrupt you.
yeah,
Please
definitely.
conclude.
So,
Oh.
STRIDE demonstrated a significant improvement in the median OS when they compared with the sorafenib. You can clearly see almost 36 months, they 20 versus 30, and almost 5-year data also discussed. Almost 20% patient, you can clearly say, and every one of out of 5 patient is survived with this IO combination up to 5 years. So that is quite impressive data at a patient, those who have at least survival 20% at least 5 years. So this is quite impressive with all. Next slide. Next slide. Yeah, there is a quite improvement in the overall survival as well as PFS with the all arm. You can clearly see this is the forest plots favor the IO combination when compared with the sorafenib. Next slide. So yes, you can clearly see the response rate and the duration of response was higher when compared in the STRIDE and sorafenib. You can clearly the CR rates almost 3% and PR rates almost so 17% in this STRIDE protocol, and overall response rate we clearly see almost 20% with the 5% month, and the median duration of the response is around 22 versus 18 months. We can this is quite significant, and this is quite good in the patient to improve the overall survival. Next slide. This is the safety profile. We clearly see any adverse event, any grade third or fourth event, more or less similar in the both arm. Any immune-related, definitely as we expected, immune-mediated adverse event is high in the this IO combination arm. Otherwise, more or less similar in the both arm. Next slide. The most common side effect is rhesus pruritus and diarrhea. That is quite manageable with the all treatment parameter we have. Next slide. Yeah, this is the hemorrhagic SMQ events. Yes, this is almost 1%, almost 70% of all grade, almost 1% all, and esophageal versus hemorrhage almost nil in the both arms. So that is quite impressive with this study. So very minimum hemorrhagic events we see when we are using this combination. Next slide. So definitely the first line systemic treatment, we have option of atezolizumab, bevacizumab category 1 indicator in NCCN, and the IO combination also is recommended as a first line treatment in the patients. Next slide. Yeah. So my conclusion, as this is the most common cancer affecting Indians, there is a shift from viral to non-viral etiology, especially NF-friendly. Immunotherapy combination have shown better anti-tumor activity than TKIs. IO and anti-VEGF combination is the newest standard of care. This regime IO combination has a quite excellent overall response rate, duration of response, or overall survival benefit we can clearly see. STRIDE schemes benefit all subgroups as well as viral and non-viral etiology. STRIDE was well tolerated and lower rate of discontinuation and GI hemorrhage. So STRIDE and durvalumab monotherapy represent potential new treatment option with the unresectable hepatocellular carcinoma. Quite good data, quite impressive evidence. Safety profile is quite high. Only issue I think that is the financial part. So yes. So this is the treatment option we have for unresectable and advanced stage hepatocellular carcinoma. Thank you.
Thank you, Dr. Abhishek, for your nice talk. Thank you.
Yes.
Actually, we
Thank
have
you, sir.
less time so that I cannot ask you the questions, but it was a very good talk. And now I would request our next speaker and moderator, Dr. Manoj Mahajan, for taking the panel discussion. And he will be centralized around the shifting paradigm in the biliary tract cancer. So, Dr. Manoj, welcome to you, and Dr. Jitendra Kumar Pehlajani also,
Good evening,
I
boss.
welcome to you. So both you are in the bedroom, in the relaxing mode, right?
So how much time do we have, Sakshi?
जितना जल्दी
30
बोलोगे उतना जल्दी खत्म करेंगे दोस्त
30 minutes.
हाँ नहीं मैं सोच रहा हूँ कि पहले से कम कर दो ऐसे
Yes, yes.
हाँ
So
वही
Dr.
बोला है
Pulkit is
सर ने
there. He's
So I
representing.
think I'll invite my other panelists, Dr. Jiten, Dr. Pulkit. He's there?
Yes,
हाँ
yes.
पुलकित है
sir.
हाँ Dr. Sunit and Dr. Subhash.
Yes, sir.
Yes, sir, here only.
Okay. And I would like to just to have a lighter note, this is the third panel I'm moderating. Last 1 month is the same panel, and Dr. Jitendra has been the part of all the 3 panels. So now
you
he
can skip the order questions.
he can moderate without my interference. So, and Dr. Pulkit was also like in one of the last moderation, he was there. So it's the same part, but we'll take last few practical things which we are commonly practicing, or few practice changing things which now we have adopted in biliary tract cancer in the current era. So next slide. So I'll just briefly go through the epidemiology, then we'll. So these are slides are provided by Dr. Asim. Next slide. So India has a very high burden of biliary tract cancer, as we know, mostly in Gangetic belt, and it contributes around 10% of the global GBC burden. So as per the NRCP, BTC, including there are almost 30,000 odd cases, more than 30,000 cases. Female preponderance is more. And nowadays also we are seeing a lot of biliary tract cancer in Udaipur area and probably in Rajasthan also. Next slide. In like earlier part of my practice when I was in Delhi, there where we used to see rarely biliary in most of the patients in biliary tract cancers were like in the genetic belts. So many patients we used to see. When I shifted to Rajasthan, we hardly encountered biliary tract cancer. But nowadays, in last couple of years, we have seen a surge in biliary tract cancers. So as the incidence is increasing and it is female preponderance is there. So next slide. So we'll come to the this basic epidemiology at individual practice. So the main essential thing, I'll just ask the question in a little different way. In last 10 years, a decade back, and now, what are the diagnostic modality which we have changed? A diagnostic modality which earlier we used to not do it, but now we are doing for diagnosis of BTC. Apart, Dr. Jiten.
So staging, we are having FAPI-PAP in many centers in Rajasthan. Also, people are using it. Second thing is NGS is now NGS IHC is there, which we are using very frequently. And third thing which I like to point out, now younger patients are coming with biliary tract cancer. That is a thing which is worrisome. I have seen 25-year-old with biliary tract cancer metastatic. That's very worrisome.
Sir, are you asking about biopsies which we are doing nowadays?
Yes, exactly. Like Dr. Jiten has pointed out few things, but biopsy, which like earlier we used to do FNAC for just confirmation. Nowadays we are going
हम
for
वहीं
the
रुक गए थे
biopsies.
क्या दोस्त बायोप्सी पे शिफ्ट हो गए 5 साल पहले ही
In recent decade, that is what I am asking. Recent last decade versus
सर वो
this
10 साल
decade.
का ही पूछ रहे हैं सर
नहीं इतना ज्यादा लंबा टाइम नहीं हुआ
Okay. Fair enough. So biopsy is the new thing which we have advanced to, and because of the biopsy, we are also getting into the NGS. Already, Dr. Jiten has told. So I guess Dr. Subhash and Dr. Pulkit are also adopted practice of biopsy in most of the cases, with few exceptions that we'll discuss.
Yes, sir. Yes, sir.
So, okay. So let's say where we have a difficult access for the biopsy. So what do? We go for the FNAC or we go for a liquid biopsy. Financials are not constraints as of now. We'll discuss what are the academic things which we follow without financial constraints. So for discussion purpose, I'll just financial constraints will leave aside and we'll just discuss what are the like current practices. I'll say if we don't have any financial constraints, will we go for a FNAC or a liquid biopsy? Dr. Subhash?
I'll go with the okay.
Dr. Subhash or Dr. Sunil?
Yes, sir. Sir, I will go for the, if it is possible, then I will go for the MRCP followed by ERCP stenting and biopsy. And if biopsy is not feasible, then I will go for the liquid biopsy or NGS.
Okay. Dr. Sunil, your take?
Yes, sir. I think Dr. Subhash has pointed out fine. I mean, most of us will do that only, I believe.
So how many of patients, if let's say we have 100 patients, how many of the patients will go for the liquid biopsy considering financial constraints?
Considering financial constraints, sir, 4 भी नहीं जाएंगे.
लिक्विड बायोप्सी 4% जाएंगे ना, 4 भी बहुत है. If
So
we have good,
if you are discussing only on science, purely on science, and the patient is in BMW and everything, I think only the patients wherein we have some risk associated during procedure or post procedure, there only I think we'll be comfortable with the liquid biopsy, because we know there are a lot many ifs and buts which come across with each patient. So I believe the liquid biopsy is only patients may, I think, in a general routine practice we carry out on a general note.
So, but
okay,
I had a point to make, sir, here. You
Yeah.
have asked about FNAC versus liquid biopsies, correct?
Yes.
Yeah,
No,
I'll
no, sir,
definitely go with
question was I think it was biopsy versus liquid biopsy, right?
no FNAC
No,
versus liquid biopsy.
Okay, then
biopsy
I
now
might
we
have
have
heard it wrong. I might have heard it
Then
wrong.
I'll definitely go with FNAC. I'll even if it is affordable, I'll keep liquid biopsy as a second option.
Sir,
If
so
it is
it will be
showing FNAC,
biopsy, FNAC and liquid biopsy. ऐसा ऐसा रखें हम लोग मतलब.
yeah. I think
no, the
I agree
question
with the
was
plan. Biopsy.
question
Listen to the
was where,
moderator.
let's say biopsy is not possible. In that case,
Yes.
where will we go? That was the question.
So
Okay.
Dr.
If
Manoj,
the,
the
FNAC
ideal
was
way
not an
is
option.
FNAC to prove malignancy, or a ERCP brush cytology to prove malignancy, to stand up in the court that you are right or you were right by treating that patient. Second thing, what we can do means, as I have already told in the discussion, the previous we had, that at HCG we are doing NGS, CGP and 65,000. If that CGP from the biopsy fails, reflexly they will do 70 gene panel NGS from the blood itself. So that is probably a win-win situation for me as well as patient, because those 70 gene probably will have everything including IDH, HER2 and MMR proteins. So that is the probably way to go.
okay, so you will go for FNAC as well as liquid biopsy, correct?
Yeah, means FNSC will not give you any other
No,
advantage
yes,
except saving
I'm
your
just
thing.
asking where the biopsy is not feasible.
Yeah,
We have
yeah,
concluded that we are doing biopsies for most of our patients, but sometimes there are biopsies not feasible.
yeah.
So in that case, in that subset, I'll say whatever, like 10% of patients, we may not be able to go for the FNAC biopsy. So in that
Yes.
10%, how will we proceed? That was my question. So we'll go for the
Can I
FNAC and
answer,
then
sir?
liquid biopsy.
I have understood the
Please.
question now.
Mm-hmm.
So NGS becomes a mandate when you encountering BTC nowadays. So NGS आप biopsy से भेजें या आप liquid से भेजें, that is a separate topic of discussion. And if you have a biopsy tissue, no doubt the NGS goes on that. If you are not able to get that chunk, if you're landing with an FNAC or a brush cytology for that matter, in that case, I think liquid biopsy is the one thing which we rely on for an NGS. Or I think third proposition tab aati hai when we are not able to insert a wire and get some FNAC oblique a biopsy. In that scenario, liquid biopsy rules the roost. I think if I'm putting it in perspective for all of us, I believe, if I'm not wrong. Manoj sir?
Yes. So I think that's the correct way. We have to, both the points are well taken. Like Dr. Jiten has, we have to prove if FNAC will just prove the disease, and then if we have add-ons like for the mutation purpose, we'll go for the a liquid NGS. What is the gross distribution of cholangiocarcinoma versus GBC? Dr. Subhash?
Sir, in my current practice, cholangiocarcinoma accounts around 50 to 60% cases, and biliary tract cancer, GB cancer is around 20 to 30%, sir.
Okay. Next slide, please. So any molecular marker that we have discussed. So if let's say if we have limited like resource setting, which is the one test to go for on the biopsy for molecular testing? Dr. Subhash, you can take this.
Sir, in my current practice, I prefer in all patients the comprehensive NGS panel, which include the NTRK, BRAF, KRAS, RAT, FGFR, MSI, and HER2 also. And
So,
it covered the most of the target actionable mutation. Though I will go for the comprehensive NGS panel, sir.
no, I'm asking in a all resource restraint setting, where there are constraints that you can't do the NGS for all the patients financially. everybody accepts that. So, but there is only one test, like we have already mentioned. I'm just making a point out here. We should do at least HER2 for all patients.
Yes, sir.
Yes.
Rest, if patient is affordable, then definitely we'll do all the tests. NGS, everything will include. But if patient is not affordable, even in that case, we should do at least biopsy plus HER2, because that will change the treatment aspects.
Yes, sir.
So, Dr. Pulkit, are you agreeing with this?
Yes, sir. I think HER2, if one test to choose in a resource limiting setting, I think we'll choose HER2 only because of the facts available that we have a target therapy available, and the chances are around 10 to 15% coming out to be positive. So if single
Yes.
market to be chosen, HER2 will be the choice.
Okay. Next slide. So these are the molecular mutations usually seen in the BTC spectrum, where we can see HER2 is positive around in 10 to 15% patients, mostly from extrahepatic compartment to GBC. Intrahepatic, it will be less common. In that intrahepatic compartment, we'll say KRAS, FGFR, IDH will be more common. Extrahepatic cholangiocarcinoma, KRAS would be predominant, and in GBC, KRAS, HER2, CDKN to be ARID1A. These are the more predominant mutations that we see. Next slide. So these are the current recommendations, and we have discussed most of the recommendations, including palliative care from like ERCP guided biopsies, brush biopsies. Next slide. So we will quickly move to one case we'll discuss. So it's 55-year-old male, 5 years history of hypertension and dyslipidemia, presenting symptoms of yellowish discoloration of urine and persistent abdominal pain, liver function slightly deranged. Lab tests are showing hepatitis marker negative. CA 19.9, 982, CA is 9.8, AP is normal. HER2 biopsy is negative. That next slide. So imaging is suggestive of there is dilated intrahepatic ducts with the anterior segment of the right hepatic lobe and the medial segment of the left lobe of liver, and with heterogeneously enhancing mass at the confluence of right and left hepatic duct. So it's a intrahepatic cholangiocarcinoma, confirmed by the PET scan also. Next slide. And biopsy is suggestive of moderately differentiated adenocarcinoma, HER2 negative. So final diagnosis to conclude is intrahepatic cholangiocarcinoma, metastatic, HER2 negative. Patients, all the other functions are normal. How do we proceed? In non-resource constraint setting. Dr. Sunit?
Sir.
If you have all the options available,
So
how will
IO
we
plus platinum based chemo. I
Okay.
think GEM says GEM carbo or IO plus IO.
IO plus IO?
Not in this case, sir.
No. What are the, so for this patient, how will we proceed?
I think
GEM
patient
carbo
is
plus
fairly
IO.
fit enough. Yeah, GEM says GEM carbo, anything.
Okay.
Plus IO, sir, I would go.
IO, which IO will you prefer? Any preference for the IO?
सर पेशेंट रोल्स रॉयस वाला होगा तो दुर्वा नहीं होगा तो पेम्ब्रो.
ओके.
सुमित के पास पेशेंट आ रहे हैं BMW वाले.
सारे BMW वाले हैं.
हाँ वही बोल रहा.
Okay. So is there any point where we will choose a Pembro over a Durva or Durva over a Pembro?
The data with Durva was actually quite promising again, but Pembro's checkmated is also better. I can't compare the two things. But again, I think Durva lands in a better shape when it comes to overall response rate.
Okay. Even there are few points I'll just make. Dr. Jiten, you would like to highlight any differences between Durva versus Pembro, where you will prefer?
Versus no, the point is Durva I will prefer because it has less chemo. You don't have to give gemcitabine maintenance. So that way your life will be easy. as a medical oncologist. No thrombocytopenia, nothing. If patient responds, they will respond on immuno only. So because maximum 8 cycle of Jamsys, that's the best deal. Otherwise, what the data is more or less okay. Slightly difference in HR 0.80 versus 0.83, but I can take both the options. But Dhruva is slightly better, scores
Overall
better over
response is better
Pembrolizumab.
with Durva, which is studied, sir. Overall response is also better with
Yeah,
Durva.
that is also better. HR is also better.
HR is also better.
The OS data so far available is highest for the Durva. Almost
This
3-year
Durvalumab.
OS data is around
Yeah,
15%
long-term
versus
studies.
7 gram. So looking at the data, Durva definitely scores over the Pembro, but we have like adequate data. Probably the largest trial, largest number of patients were included in the Pembro arm. If the patient has, let's say, pneumonitis or previous history of ILD, will he have any choices? Will choices differ in Durva versus Pembro? Dr. Subhash?
No, sir. I will go for the Durvalumab. I have don't seen even any patient of pulmonary pneumonitis.
Okay. Dr. Pulkit?
I'm not aware, sir. There might be some difference between Durma and Pembro, but honestly, I'm not aware which is better to choose in pneumonitis. What I can say is if there is a well-established history of pneumonitis, I would like to avoid immuno because it might flare up. It might be because a contraindication to give immunotherapy if patient has already have a history of severe pneumonitis. So I would like to hold immuno for a while, but which immuno to choose into both of them, I'm not aware of it, sir, honestly.
Okay.
So one point I'd
So,
like to add, if somebody has a history of skin disease, like a psoriatic patches or something like that, definitely Pembro is to be avoided. Because in real life scenarios, we have seen worsening to
Yeah,
severe
yeah,
worsening of skin
yeah, I
rashes and
agree.
reactions
Agree.
with
yeah,
Pembro.
same stands with the
So,
pneumonitis. There are if we look at the adverse events related to the immuno,
mhm.
the PD-1 blockers like Pembro has higher chances of pneumonitis as compared to
Okay,
PD-L1,
PDL1,
including
yes, yes,
Durva.
yes.
So
okay,
if the patient has such history, will prefer a Pembro over will avoid the Pembro
Avoid the
and
Pembro.
prefer a Durva. So the data is also even the large data related to the side effects profile. So Durva, it can be a go for
So, sir,
molecule.
will Durva be safe in the patients with a history of pneumonitis, even being
Yes,
engaged with
history of
PL1?
pneumonitis, controlled pneumonitis, I'm saying, not active
Okay,
pneumonitis.
okay,
But in Pembro, it will be a relative contraindication because because the Pembro has itself has higher chances of pneumonitis
pneumonitis.
compare when we compare Durva and Pembro. So we
Okay.
should definitely avoid the one which has a higher chances. Okay, so there here one more scenario I'll just add. So now we have coming a lot more data of low dose in head and neck. Now low dose Pembro has come in breast, like Indian data has come recently been presented. So are
Yes, 50 mg
we
data.
any of us practicing low dose immuno in cholangiocarcinoma or
Mhm. So
will
far, I
dare to?
haven't.
Will dare to, Dr. Jiten?
Will dare to,
No, no,
definitely,
no.
sir. Will dare to,
No, I
in
will
near
not.
future we will,
I
but
will not
not
dare.
right now.
नियर
I am
फ्यूचर
not.
दोस्त तब तक जेनरिक आ जाएगा दोस्त
नहीं नहीं,
पच्चीस
Sir,
तीस
वो
हजार में
आएगा नहीं.
sir, 6
क्यों
months
नहीं
down the
करना
line,
चाहेंगे?
इनी
क्यों नहीं
मिनी
करना
माइनी मो
चाहेंगे?
करके
If
देंगे
you
लोग.
don't want to give, why don't want to give low dose?
भाई
Sir,
जेल
the
जाने से
only
बचना है जीवन में जो किताब में लिखा है गाइडलाइन में लिखा दो खुश रहो सो
ठीक है.
करो
So Dr.
बहुत
Jiten will go
सिंपल
with the low dose. Dr. Pulkit?
I think the reason to choose loaders, if what I am considering is the financial constraint, right?
Yes, yes. Obviously, we are just now
That,
discussing the
yeah.
practical
So,
scenario where, like,
yeah,
probably
yeah,
80% of our
yeah.
patients
So
will
why not?
require.
Yeah. So why not we have now in the market, I will not name the brand name, but now we have a different IU available in quite a cheaper cost. And they are showing quite promising data by showing their Kaplan-Meier
Sir,
curves in Indian patients and abroad patients. So why not to choose that instead of going low dose Durva or Pembro?
But
Pulkit sir,
is there any?
sorry to interrupt, sir.
मैं वो भी यूज नहीं करूंगा
Si-
क्योंकि उनका भी अप्रूवल नहीं है मैं पहले ही बता
उनका भी
रहा हूँ
अप्रूवल नहीं, हाँ,
Sir,
उनका तो अप्रूवल ही
6
No,
नहीं
no,
है.
months down the line,
approval is an issue.
सर 6 months
Yes,
down the
sir,
line,
please.
जैसे रोटी बास्केट होती है वैसे बास्केट लगी होगी आपके पास. You have to choose इनी मिनी माइनी मो क्या
100%,
लेना
sir.
है.
And I think it is good for the patient. It is good for
It
the
is good
Yes,
for
patient
the
if we
yes,
have a
patient.
proven
for the
therapy.
It
patient.
is good for
It
the
is good
choices
for
are
the
good for the
patient.
patient. Choices are
So,
good for the patient.
Dr.
Yeah,
Pulkit will
yeah.
choose if you are to choose a low dose, will you choose any of them
No,
and what in what
no,
dose?
I will not choose.
No,
I
sir.
will not choose.
I will not.
So two panelists have clearly denied. Dr. Sunit and Dr. Subhash, your take on this?
Sir,
No,
I
sir. I
need
will not choose.
मैं
In no dose.
एक जेनरिक जवाब दूंगा सर जो हर पैनल में बैठ के देते हैं. I need more data.
Agreed.
Yes.
I need approvals also. I'm a
Dr.
married man. I
Subhash?
need approvals.
Yes, sir. I will wait
सर
till
अप्रूवल के बिना तो फुल डोज भी नहीं दे पाएंगे सर. अप्रूवल तो चाहिए ही.
हाँ, ये तो.
Okay. So I'll just share few data. There is Japanese data which has like even durvalumab they have tried and PK. These are very early studies. I'm not saying practice changing. I'm just saying to sensitize our mind in that sense. We can use to certain extent if at all we are convinced with the PKPD data. Japanese data is showing durvalumab can be used around 6 milligram per kg, and there are few other studies which have established that 3 milligram per kg of durvalumab will saturate most of the PD markers, PD-L1 markers, as compared to 10 milligram, which we normal dose is 10 milligram per kg. We
10 milligram per
use flat dosing 1500 milligram, so it comes around 10 to 12 milligram per kg. So as compared to that, 3 milligram per kg will also saturate the similar level of receptor saturation. That is
Sir,
the
that
lowest we can.
was proved with another. Nivo had proven that.
Nivo also 1, 3,
Nivo
10
had
No, no.
proven
was
it
there.
beyond doubt, sir. The receptor saturation remains for 100 or something days, and that to 140 microgram per
No,
millimole. That was the
I'm
study.
not talking about Neo. I'm talking about durvalumab.
I
Durvalumab
know,
has
sir.
also.
I get it. So PDL1
Yes.
saturation remains for a longer time, but obvious that is was proven by Nivo
So
also that
that is a like hypothesis generating. We can say we
yes,
can
yes,
collaborate
something,
in
yes, like
multiple
that.
sense. Like that, this can be rolled on 3 milligram per kg. We can definitely we can have 40-50 patients data where we can establish in both ways, prove or disprove in that scenario
Thank you,
what
sir.
is
अगले
the
You are
साल के
data.
disproving.
एस्मो के लिए
I
आपने
am
थोड़ा
not
आइडिया
part
दे
of
दिया.
this.
ऐसा करते हैं तो रास्ता
If
बना
you
So
are
लेते हैं.
disproving, I am not part of this.
3 milligram is the lowest and 6 milligram per kg has Japanese data is there to like have similar data. So I think lower dose we can think about it if we have like this is for hypothesis generating or conducting a collaborative study at multiple centers. Like we had done this on the cholangiocarcinoma only, that will follow. I'll just brief through what we had done. So we have discussed most of the part of this case. Next slides. So next slide. We just flip through last part. I'll be discussing this. We have already discussed. Next. 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 Go to the almost 3-4 slides ahead. Next slide. Next slide. Next. 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 So last part we had. This is the Indian data. Just one slide. This was Indian. One slide earlier. One slide earlier. So this is James's plus durvalumab experience in advanced BTC real world data. Dr. Vamshi Krishna led this collaborative study. We had also contributed from Udaipur of Indian data, which was exactly matching the PFS, OS, and side effect profile was matching with the main study. Next slide. So this was the percentage distribution of the patients. Next slide. PFS of 8.2 months, OS of 12 months. Next slide. And the side effect profile grade 3, grade 4 was around 7.4 as compared to 12.7% in Topaz. So these were new patients. So we were cautious probably that would be the one of the reason. Next slide. So this is the standard of regimen. So I would like to conclude by saying we can conclude if we want to go for the low dose and widely wide distribution of the immuno plus chemo combination in most of our patients where we are not able to practice because of constraint setting, resource constraint setting, we can consider a collaborative study, and Dr. Asim can take the lead, and we can all collaborate. Thank you.
Thank you, Dr. Manoj. Actually, we could not contributed much in that study, and I guess we were not aware that this part of this kind of the study is going on. But yes, we can contribute in the next study, and we can also lead. Thank you very much, Dr. Manoj, and thank you all participants and panelists. And it was nice moderation by you, Dr. Manoj. So maybe in the next month you will have some more moderation with on this same topic, I guess. So in some part of the India.
Yes.
Yeah.
Thank
So
you.
thank you, Dr. Manoj, Dr. Sunik,
Thank you, all the panelists. Thank you.
Subhash,
Thank you,
and Dr. Pulkit Nag. Thank you very much.
Thank you.
We will leave. Yeah.
Yeah.
Thank you. Thank you, everyone, for joining for 2 days academic feast. Thanks to my colleague, Avni and Sakshi, and thanks to support team.